Good morning to all. First of all, I thank you, the organization, for inviting me, for giving a chance for this to presentation. This lumbar spondylosis, actually it is works as a synonym for backache. Almost all the back pain is related with the spondylosis. And unfortunately, this is the least described disease in our classics. There is no direct references for back pain in the classics. Only in the Gadanagraha, some Kadigraha, it is told. Either we have to think that at that time it may not be a major problem, but nowadays 40% of the general practitioners is dealing with the backache and other spinal diseases. So we have to know this disease from other sciences. So there is possibility of from the modern knowledge only we are coming to know much about the spondylosis and other things. So in my paper also some repetitions of Dr. Sudhi Kumar's paper may be there. And I concentrate on this particularly of the management of Ayurveda and mainly two things. One is on external application, that is Kadi Vasti, and another one is invasive, that is Vasti. I am presenting for this mostly for the students because it's a worked out things. It is not only, it is clinically worked and the statistical data are with statistical data I am presenting. So most of the differential diagnosis also come to know that we have to general disease only I am dealing with. So that is as well it's a state of back pain, or this is the second most common disease, or it's considered as a synonym of back pain. There is a wide range of etiologies. So the possible differential diagnosis are more because from the age or your sitting posture or your occupation, all comes to the cause of the back pain. So how it can be differs. Maybe applied specifically, not specifically in all degenerative conditions affecting the disc, vertebral bodies and associated joints. Primarily it is a degenerative condition which affects the lower spine. Because even it is cervical region, it can happen, but in the majority of the spondylosis occurs in the lumbar spondylosis. That is because of weight bearing and other nature of things. And it can be two types. That means though it is a degenerative disorder, it can be primarily due to the face and joint degeneration, or as a secondary to the disc degeneration. That means the alignment may be altered. Or the spinal alignment altered and face and joints will be involved from the. So two types of arthritis. First one is there is a spinal osteoarthritis itself. There is a synovial joint or the interface and joint, primarily affecting the joint. And second one is the alignment, disc degeneration and alignment is lost. So again the face problems because these two can be considered as a lumbar spondylosis. Here spinal osteoarthritis. There is the joint space narrowing. How joint space is narrowing? There is a biochemical breakdown of the articular cartilage inside the joint. So it's a biochemical breakdown occurs. There can be a reduction of space of in between the face and joints. A space can be reduced. That is why what we are seeing in the X-rays, reduction of space. Then there is a subcondylar sclerosis. Subcondylar sclerosis is nothing but it is a regenerative process of to correct the degenerated cartilage or breakdown cartilage. It is regenerating through the vascular supply. So sometimes it may be entire area of the articular cartilage will be. Sometimes only degenerative condition will be in the one margin only, but sometimes it will be affected in the total because there is no specific regeneration capacity of the vascular. So the blood supplies will be giving more, all the articular cartilages will be getting nourished, well nourished, so there will be a multiple layering of the new bone cells. That is called subchondral sclerotic change. There is a main reason why, so we are, otherwise you would say there is a reduction of space. We are saying the reduction of space and narrowing is there. That means articular cartilage is degenerated, there should be space should be increased. But actually what happened, the space is reducing because this subchondral sclerotic change, there is a regenerative thing happen. Then primarily then the osteophyte formation. That is a marginal osteophyte formation. Why this? Because the cortex and medulla is different in density. The cortex parts is thicker, so it's a stimulated reasons. Due to stimulation, it getting this spur formation. That is why the osteophyte. And what is the cyst formation? Cyst formation, that is lamellar pattern of that bone is altered. You might have seen in an X-ray of a long bone, there will be parallel linings inside it. That lining due to compression, that is lost. When it is lost, it appears as a round shape. That is called the cyst formation. This is a stage by stage. First we will be showing the reduction of the space. Second is osteophyte formation. Thirdly, the subchondral sclerotic change, and finally the cyst formation. That means the duration of we can visualize from the X-ray itself the duration of the disorder. Then when it comes to the disc degeneration, there is a degenerative, as shown by Dr. Sudhi, it is a dysfunction phase. How it happens? We have to know this stage because the presenting symptoms of the dysfunction stage and the marginal osteophyte change will be different, or facet joint will be different. There predominantly will be Vata Pitta symptoms will be there. When it comes to disc degeneration, if it is in the first phase, that is phase 1, what is happened? Repetitive micro trauma causes TAs first linear, then to circumferential. That means the disc will be either way, we can say it is a Vranasubhava. That is a micro trauma occurs and the linear TAs appears. Ultimately final tear. That means there will be a Shadoshma, presence of Shadoshma, or involvement of Pitta will be in this first phase, and the character of the pain will be differs from the earlier one, and this character will be the burning type of character will be there. In the facet joint degeneration is osteoarthritis, there will be pain comes and goes. There is no continuous pain. But here if it is a dysfunctional phase, in the degeneration itself, it can be a involvement of Pitta will be there. So the character of the pain can be a burning type. And when it comes to the instability phase, loss of mechanical stability due to tears. That means while moving, the pain can be increased. While rest, the pain can be reduced. And that means if you are assessing the pain character one by one, you can think it may be due to the phase 1 or phase 2 or a facet joint involvement. Then what again comes the phase 3, that is stabilization. How is it stabilization? The annulus fibrosis sclerosis. That's again multiple layering. The regeneration is what you can have to think about the anatomical structure of the nucleus pulposa. What is it? That is primarily collagen, and the proteins, protoglycogens is there. Just like our eyes, we are lens, we are having the proteins. When it is lysed, it becomes, that is your vision is changed, that becomes what it is called, we call it as thimera. Just like here also, by aging the glycogen, the protoglycogens can be, it lyses. So that is comes there is a dehydrated state of the nucleus pulposus. Here then again automatically the stabilization, that is a sclerotic change and fibrosis, and thereby reduction of space in the reduced space will be reduced. So this alters the facet joints, alignment alteration, and that ultimately the facet joint will be again deranged. Then come to the risk factors, as I told, age. As age increases, the healing ability of the body decreases. That's how I told the linear trauma, and I told the repeated trauma cannot face the same age of a 20 years boy. He cannot face the about 40 plus. That is a degenerative condition age. So more prone to lumbar spondylosis. Then again, next one is obesity. Overweight put more pressure on the joints of lumbar spine. Then again prone to lumbar spondylosis. Then sitting for a prolonged periods, that means which puts the entire body weight onto the lumbosacral joint itself. That means prolonged, that's why it becomes a causative factor. Then putting pressure on the facet joints, and particularly this will be in the L5 and S1 joint, then that also prone to lumbar spondylosis. Then there is if it is a prior injury, is already occurred, repeated injuries, there is then susceptible to develop lumbar spondylosis. And hereditary factors, that is what all the glycogen factors and all that is hereditary. These problems can be hereditary also, because there is lysing in the early age, starting at that, so there is a hereditary factor also develop lumbar spondylosis. Then when come to the clinical features, because these clinical features has to be in mind, then only the real differential diagnosis can be made. Backache worst during activity. Then in normal condition, the pain comes and goes. That is in lumbar spondylosis, it may not be a continuous pain. Backache worst during activity, accelerates the pain. Then feeling of a catch while getting up from sitting position. This is a typical character of a lumbar spondylosis. When the patient getting up, he will feeling a catch-like sense. That is something is caught in. That is a typical character of the lumbar spondylosis. Then sometimes it may be, it is not, when it is compression comes only, the radiating pain to lower limb, particularly everybody knows that is due to the along the sciatic nerve, so the posterior part of the, up to the heel it can be possible, or to the great toe, up to the great toe, depends upon which nerve is, primarily root of the nerve is involved. Then there will be transient numbness. There is a transient, not on the as said by Dr. Sudhi, there is no neurological deficit or continuation. There is a transient numbness can be there in the spondylosis things. And that particularly will be commonly on the lateral side of the thigh. That depends on the dermatomes and you might have seen it. Then morning stiffness is common. This is particularly, you can say, if it is due to the facet joint problem. Not disc problems, facet joint problems, this will be predominant. If he is aged person, 50 plus normally of the male and 60 plus of the female, this lumbar spondylosis is more prone to that age. If his morning stiffness is getting in the back, that primarily we can think there is a arthritic change. So the facet joint, the osteoarthritis may be the problem. That management will be different. If again the management will be different from if it is problem. That so you have to be whether this morning stiffness is there or not. There is a prasar naganjana or that is the same as Sandhikadavada. You have to think about these things. Then as examination of neurological test, straight leg SLR, the common thing, that up to wear abstent and LSA test, pump handed test and Gensler's test. These are the tests commonly using in the clinicals. Then investigation, as I told earlier, X-ray, AP and lateral view. Then reduction of disc space, osteophyte formation, narrowing of joint space and sclerosis. As you might have seen the X-rays, there is a reading of X-rays, there is a things, that is the ABC approach. For reading spinal X-rays, there is an approach that is called ABC approach. A for first for alignment and B for bone. That means bone density, margins, size, shape, all the things of the bone will become. Then C, the cartilage and soft tissues. That is the ABC approach we are approaching for if reading. Most of the students are thinking that will be starting this alignment. First we will be looking for the alignment, and particularly in the both AP and lateral view you have to be fallout. Lateral views are more for alignment problems. Then only we can think how far we can manage these problems. Suppose you might have been about spondylolisthesis. It is divided with different grades. Up to grade 2, Ayurveda can manage very well. If it is a grade 3 and nothing, the grading is nothing, simply for the displacement. Well, come to the listhesis, I'll show you that. That means there is we have to know the merits of Ayurveda and demerits also. How far we can engage in this management program. If it is a grade 4, why should we dare to that? We cannot cure that condition, grade 4 listhesis. So this alignment reading should be very well of the students. That means they have to know how far this displays, how far alignment is altered. Then we can think about whether it is manageable with Ayurvedic things, as Dr. Sudhi mentioned. What we are doing for neurological deficits. But naturally, neurological deficit, we think how it happens. Then only we will involve it. Whether it is involved into the synovial fold involvement is there, and then the management will be different. If it is the structural unchangeable thing, then it will change. Or normally we will say traction massage and other things if it is involved is there. So then the blood test to exclude any systemic diseases, because if you have to rule out lumbar spondylosis, is clearly no other systems are involved. That means if a tuberculosis condition, spinal problems can be there, or in any other even DM patients will be having so much pain and other things. The aggravating factors can be there. So to exclude any systemic disease, you have to routinely blood test again. Then CT scan is useful to determine the bone problems, and MRI is the golden standard in investigation spine. Of course, it will be a little costlier, but you have to go for this. Otherwise, some multiple myeloma, other way we will, but we will miss the problems. We will think, and we will directly go to this back pain and all, and we will ultimately the patient will go to paraplegic condition and all. So you have to go for MRI as far as possible is there, because if you are getting any doubt in your mind, definitely you have to go for it. This. Its alignment, if you have shown, that is anterior, and as shown by Dr. Sudhi, anterior line, posterior line, then pedicular line, then the ligament of flaval part, that is 5 lines here for alignment, other things. Then comes to differential diagnosis. Almost all the back pain disorders can be considered as a differential diagnosis of lumbar spondylosis, because only the character of the pain, pain is always a universal. That is, almost all the patients will be having pain. Only the character and the timing or accelerating factors will be differs. So you have to think about all the factors of differential diagnosis. There is classification of back pain. This is just for students only. There is intrinsic and extrinsic. Generally, we can say this for either for writing exam. That will be better to remember this way. It is a congenital, if it is a spina bifida and spondylosis are considered as a congenital causes, and traumatic, there is a lumbosacral strain. That is the most common back pain. There is a lumbosacral strain is the most common that occurs to the mainly to the housewives, because they are repeated stretching of the musculature ligaments of the back. So there is possibility of the lumbosacral strain. Then IVDP or vertebrae of the fracture. These are traumatic reasons, and functionally kyphosis or scoliosis, it can be considered as a functional aspects. And inflammatory, there is arthritis and fibrosis. Then degenerative, that is arthritis, it is here it is considered as ankylosing spondylosis and other things. Then degenerative, there is a spondylosis, what we are discussing today, and osteoporosis. There is a metabolic, you can consider this as a metabolic factor also. How that is in the X-ray you can immediately notify, because if it is osteoporotic density of the bone, what is the difference in the X-ray? The thinned out margins will be there. That means brighter margins you will visualize, and a darker area of the medulla part you can see. That is typically of osteoporosis. And if it is neoplastic, primary or secondary, or the primary due to that spinal tumor, or it is secondary to some other mechanical pressure compressing due to other nearby organs and all. If you are considering the extensive factors, the most common is pancreatitis. There is a common disorder which can affect the patient, can come only as complaint as a back pain started, because in particularly in Kerala this is more. In other parts of the country, comparing to other parts of the country, in Kerala this pancreatitis is more. Most for one of the reasons tapioca, usage of tapioca is considered as one of the factor. But this can be presenting a complaint as a back pain, as the patient can come to your clinic as a back pain. And of course, cholecystitis, gallbladder stone can be another problem. Then is a pelvic inflammatory disorders, PIDs can be there. Then genitourinary, that is renal calculi, there is a very less only, because the patient complaints of the pain of the back will be different of the back pain and renal calculi back pains. And vasculitis is ischemic pain from occult arteries. There is another possibility of that is abdominal aorta and other the blockage is, or internal that is iliac artery blockage also. Then the patient also complain of the back pain. Sometimes we may entirely miss these problems unless and until if you are not regularly checking the vascular reasons also. That means normally the pulse of the lower limb also we have to go through. Otherwise you may not at all get a doubt about these reasons. Then psychogenic, of course, there will be tired syndrome and all. The patients will be complaining in the evening, the backache and other, or to avoid some job and other thing, they will say, I am getting backache and other. Psychogenic, whatever treatment management protocol we put it, the patient may not get the relief. Then one by one, just one few slides only, there is a lumbosacral strain. There is a commonest variety of acute back pain, usually caused by strain, stretching or repeated stretching and tearing of the ligaments, particularly of the posterior longitudinal ligament, because anterior there is, and of course you may be knowing the anatomy of the extensive group of muscles and interspinous and transverspinous muscles and paraspinous things. This repeated straining of these things, it can happen. A lumbosacral joint is forced beyond the normal rate. Here the patient comes with lumbosacral joint pain also. Then here they differentiate, first we differentiate how will the back pain, plus the patient will say, I am getting more pain on the iliac crest area. That means lumbosacral joint will be getting more pain. Then you can get a doubt. What is the other thing? All the radiological investigation will be, nothing will be contributing to this lumbosacral strain. Only the history and the site of the pain and acute onset, all the movements are restricted. These are the signs and symptoms we are getting. There is no, even SLR will be positive sometimes, because that depends upon the condition of the patient, and all the radiological and MRI will be to rule out this lumbosacral strain only. But unfortunately, the most of the patients majority of the patients will be having lumbosacral strain. Only thing it will be repeated. Or if you are applying some counter liniment or some oil and gets vaporized in their area, the steam bath or something, then immediately he or she will get relief. Then again comes after some time. That history you can say. The localized pain and tenderness, this you have to think it is a localized pain and tenderness. All movements are restricted and rarely the spelling mistakes are rarely radiates. And chronic, it occurs in individuals with poor musculature, incidence onset, frequent attacks, pain and restricted movement will be there. There is the obese patients will be having more, and particularly of the housewives, majority of the will be having these problems. And another one is the fibrositis. That is the muscle fibrositis only. The tender nodules lying superficially in the erector spinae muscles. You can, if you are palpating that area, you will may get a feeling of the nodules. Then if you are getting that are the erector spine, that is the erector spine area, you will get a nodule formation. Then you can think about a patient complaining about it, and radiologically there is nothing visible. So you have to rule out this fibrositis. Pain and flexion is restricted due to spasm. Here you have to think flexion. There the lumbosacral strain, that all the movements are restricted. Here the flexion is primarily restricted. While stretching the muscles only it gives problems. Then the spina bifida, just for the students, the congenital defect in the posterior bony wall of the spinal cord. There is a congenital problem, and the spina bifida, out of this all meningocele, myelocele and meningomyelocele, spina bifida occult only happens to come to our clinic, because of the majority of the other will be the younger age, and normally myelocele when go beyond before without surgery they can't live. So spina bifida occulta will be, you can get as a back pain. What happened? What is there is a fibrosis. Instead of a bony union, there will be a fibrous part union. As you are knowing, the spine is it's a modified. It is a two-part in the joint. When it is not a bony union, fibrous part will be there. Then it creates a spina bifida occulta. Then the scoliosis, that is a non-structural and structural can be structural. Structural can we cannot correct it, structural things. The non-structural scoliosis only Ayurvedic and structural also, if the Cobbler's angle, that Cobb's angle, if lesser than 25 degree, we can go for management, conservative management is, and that means X-ray will be there. The Cobb's angle, how to know that? That normally structural things, surgical corrections only, but if the Cobb's angle will be lesser than 25 degree, we can also manage a certain. If it is a earlier occurring postural, compensatory and sciatic scoliosis, this can be corrected Ayurvedic manage. If it is a congenital paralytic neurofibromatosis idiopathic, and that things is not be corrected by Ayurvedic way. This is one thoracic scoliosis and another one is a lumbar scoliosis. The maximum degree of the compression, that is change occurs. You have to draw a line like that. That's why the corpse angle is then the ending of the curvature, you again draw a line. When these two lines meeting and you can measure the angle, if it is lesser than 25 degree, then we can, there is a corpse angle. If it is 25 degree lesser, then we can go for a management of Ayurvedic. We can correct with Ayurvedic management with back support. That dynamic back support with definitely not corset. Dynamic back support plus this our massage traction, counter traction, that is because wherever this muscle is, we have to massage technique is entirely different, not normal massage. That type of massage plus the back support, we can correct it. If it is the corpse angle is 25 degree, that is the first thing into the mind. You have to know it, this X-ray, you can know to read the X-ray, then you can think whether it's Ayurveda can manage it or not. Then lumbar canal stenosis, there is a pain incidence onset relieved by sitting in line and neurological claudication. You might have heard about a claudication in the peripheral vascular disorders. What is the difference in neurological claudication and peripheral, there is vascular claudication? Vascular claudication is, neurological claudication will be bilaterally, commonly it will be bilaterally, not unilateral. That vascular claudication will be commonly in the unilateral, only one limb affected, and where the blockage occurs below that, distal to that part only, the claudication part. Here there is a back area, that means both buttocks and if it takes rest, immediately this claudication takes. Where in the neurological, the vascular claudication is boils is graded into grade 1, 2 and 3. So it can sometimes with the claudication with the pain also the patient can walk. And here it cannot be there. The neurological immediately the patient has to take rest and within minutes he will be able to walk. That is the difference between neurological claudication and vascular claudication. So here this will be lumbar canal stenosis will be there, the claudication will be there. Then the IVDP, that's, it can be traumatic, it can be increase in the tension. If it is traumatic primarily occurring, there will be L4, L5 will be involved. If it is a traumatic reason primarily happen. On degeneration, if it is, then it will be L5, S1 will be there. That is a two common findings. You have seen the earlier pictures, there is a prolapse of this one, this of L4, L5. You can see there is a first one, right side T1 and T2. This also you have to know how to read this MRI set. This based on mobile proton density and the relaxation time. The T1 and T2 is the difference. At least you can have to know one appearance of the CSF and the spinal areas. The this prolapsed areas will be deferred, and this disc also here be in one picture it will be in the whatever left picture it will be more brighter and the right side picture will be darker. That is first one is the T2 and the second one is the T1. That is nothing, simply you can read all. It is easier to read than X-rays than MRIs because this is based on some certain only mobile proton density and the relaxation time. So if you are correctly reading, why it is appears, one appears in the darker, that is NH. That if you are going for a theory part, that is NH will be different than other things. But only as students you think the brighter fatty material will be in T2 and T1 it will be dark. Just simple, because for examination purpose I am saying, because basically I am a teacher, so how to identify these things, the students I will tell you. If you are forgetting all the things, just simply as you might have done the same thing in the physiology slides and all, or anatomy slides, just a macroscopic you can read it. Just like this also you can go for it, this is darker fatty things, whitish appearance, that will be T2 and other will be T1 will be there. And T1 for anatomical purposes is not changing and T2 for pathology. But fortunately all the brighter things, all the pathologies will be brighter in T1 and T2. Then acute and subacute pain. Here is the IVDP clinical features. Acute or subacute pain usually followed by referred pain. Here in lumbar spondylosis sometimes only radiates. This it is a must. IVDP almost all will be followed by referred pain. And paresthesia, that difference of sensation will be there. And restricted movements will be restricted. Theoretically, only bending will be restricted, but the patient will be having all the movements will be restricted. And particularly lateral bending. This only theory says lateral bending, but the patient will say, I can't sit properly, I can't stand properly, all the movements will be restricted. An examination, there will be a lumbar scoliosis and palpation, there will be local tenderness, and movement will be flexion, extension, and limited wasting of the muscles will be there, and power, dorsiflexion and plantar flexion of ankle joints will be lost. Then the spondylolisthesis. The deformity, this is also considered as a congenital deformity of lumbosacral region produced by gradual slipping forward of lumbar spine over sacrum. There is a 4 varieties: spondylolytic, congenital, degenerative, and traumatic. Just forget about that things. Here, this the slipping of L5 vertebra to the anterior part. You think how far that is slipped? There is a grading. If it is up to there is the other signs are there. It is called Ullman sign and other things. You forget about that things. The grade, how to grade this X-rays? Because just you think about if it is sacral vertebra, there is if it is lesser than 1/4, it is we can call it as a grade 1. If it is greater than 1/4, that means suppose the sacral vertebra length distance is 10 centimeter. If it is greater than 2.5, if lesser than 2.5, we can consider it as a grade 1. If it is greater than 2.5 and up to 5 centimeter, we can say it's a grade 2. Up to that, 2 grades can be manageable with Ayurveda. That means massage, vasti and other things you can manage. Above that, if it is more than 5 centimeter, because this is supposedly the distance, you have to calculate the distance and thing. And if it is a grade 3 and grade 4, grade 4 means all alignments will be altered. Then definitely this is a surgical pedicle screw and other things, you have to go for it. And up to grade 3 we can manage, and grade 1 and grade 2 can be manageable with definitely manageable with the Ayurvedic things. So we come to the management aspects. It's a modifying lifestyle, because if the person is continually sitting, and sitting is a cause of, we are identifying sitting is a cause, you have to ask him to, intervals, you have to walk for some time and other things. So it's a modifying lifestyle, or if it is possible, because we do occupational things, most of the system using people are coming to nowadays to Ayurvedic condition for lumbar, then you ask them to correct their sitting position and all. To take back rest has to be there, not to lean that angling of the flexion should be corrected like that. You have to, that is a modified lifestyle. Then physical thrust strengthens the paravertebral and abdominal muscles. You are just relaxating time, you can do these things. Physical therapy, strengthening the paravertebral and abdominal muscles. Abdominal muscles, never, there is a, you have to correct the obesity and other. So abdominal muscle, rectus abdominis and oblique abdominis, all have to be giving part of the back pain. You are not contributing much about back pain in these abdominal muscles also. The strengthening of the muscles, that is a physical therapy. Then general exercise which build flexibility. You think to build the flexibility, or otherwise because the most possibly lumbar spondylosis, the pain is caused due to the muscular spasm. So the flexibility you have to correct. As you know that tissue damage, muscular spasm and ischemia, these are the only three causes for pain. To assess the cause of the lumbar spondylosis, then most possibly the muscular spasm will be there. It may not be a tissue damage. If it is IVDP, there will be a tissue damage will be there. Then the pain will be tissue damage, that character of the pain will be entirely differs. Then the management possible also differs. So another factor is ischemia. Here it is to spastic condition to reduce the flexibility, increase the range of motion and strength. And back support, a corset or a brace to provide support. That is actually the modifying lifestyle. We can give it the seating conditions, and if the patient is not able to go for that, he can go for a corset or a brace. What is the difference between corset and brace also? You have to think it, because this simple abdominal binder is there. That is, we can say corset or just support. Brace means it will be additional supporting material will be there. That is the difference of that brace or corset. Then the rest combined with relaxants and analgesics. whatever the muscle relaxant, that is just if you are going any ligament, we will be acting as a counter-return mechanism, that ligaments will be as acting as analgesic, plus relaxants also, muscle relaxants will be there. Then hot or cold pack which relieves pain. Either hot or cold, that depends again, that depends on the character of the pain. You have to use the hot or cold things. If it is pitta, there is a dysfunctional state, as I told earlier. If it is a burning type of then you have to go for cold things, not they are hot. According to Ayurveda, also you have to think in the bowel managing. If the hotter things here, the type of burning is there, definitely pitta should be involved there. Then you have to avoid this. The cold application should be better than hot, because always the relieved pain will be relieved by hot things. Yeah. Exceptional things are there. In peripheral vascular disease, pain will be, if we are giving more warmer things, pain will be more. That means that there is a ischemic conditions. So here also you have to take decision according to the dosing predominance of the particular area. Your hot and cold packs which release pain, and transcutaneous electrical nerve stimulation, then physiotherapy methods is there, then traction. That is a common thing we can do. That the pelvic traction is the simple way we are Ayurvedic physician can do. The pelvic traction, there is no, even one therapist can do that traction with holding the two heels and giving a pressure to that area. That is a simple traction, or skin traction we can go for, or pelvic traction we can go for. Then that is non-steroid anti-inflammatory drugs you can go for. Then injection therapy, there is epidural steroid injection or facet joint injection is normally practicing in allopathy. Then massage therapy, that is a massage. There is Abhyanga. I am not mentioning is here, it is Abhyanga. There is a massage only. There is a give it a pleasurable pain you have to give. That is a massage, and Abhyanga is smearing of oil only. That's so the word meaning is different. Though it is synonymously used, Abhyanga and massage are synonymously used for the same wording. Here it acts as a muscle relaxant. Your spastic muscle will be relaxed. If you are applying oil and massaging that area, it's a muscle relaxant. If it is a spastic condition, that will be better. Go for massage, reduces the muscle spasm and stimulate pain inhibition mechanism. You might be studied about the pain inhibiting mechanism in the physiology textbooks. There will be which areas or massage can be done. It is a gateway blocking mechanism. That is starting. Pain inhibition mechanism is nothing. It can stimulate even with, that is why even with the patting of your mother you will be relieved by headache and other. Because that stimulation, psychosomatic stimulation of the pain inhibition mechanism is there. Pain inhibition pathway you have to read it. That means spinal column, that is why the gray matter of the spinal column is divided into 11. That is a substantial gelatinosa, marginosa, like that. Then fifth column there will be first order neuron. The pain fibers has to be travel to the substantia marginosa to the fifth column, that's called Clark's column. Then the first order neuron take place. There you can inhibit the pain. That means the acetylcholine is the neurotransmitter involved. Any medicine, if you are gateway blocking mechanism, it is something pain and sensory fibers are ending through the same pathway, and it goes through the posterior funicular pathway up to the medulla. That means in the gray mat, the Clark's column, that is the first inhibition mechanism. Then the nucleus rolando, that comes to the medulla. That is the second part where there is the neurotransmitter changes and other things. Only thing, the pain and sensory fibers entering to the same Clark's column to the posterior funicular pathway. When the gateway, that is why gateway blocking mechanism. If you are stimulating, what is you are doing? If you are bitten by something else, immediately it will go to the mouth and you will suck it. That is unknowingly your sensory stimulation is taking place. That means pain stimulus. Just like entering into the cinema theater in the beginning of the gate is blocked, just to 2:30 it will be open. So all the fellows will run into, only some fellows get into the queue. Likewise, there is a gateway blocking mechanism. Here the pain fibers are had to fight with the sensory fibers, because thousands of sensory fibers are stimulated by massage. So pain will be increased. That is a gateway blocking mechanism. Then counter irritant. What you are feeling, you are applying some elements on either you will burning sensation or a cold sensation. That's a counter irritant. Instead of pain, you irritate other things. So why irritants only sensory will the thalamus, it will be only that things. So pain will be forgotten. Then comes the spine manipulation. It functions through release of the entrapped synovial folds. Suppose the facet joint, some entrapped synovial folds are within the joint fold. It will be manipulation, it can relieve. The release of the entrapped synovial folds, then the relaxation of the hypertonic muscles. As I told, the hypertonic, there is a spastic muscles that can be relaxed. And restriction of articular or periarticular adhesions. When a joint is not at all working properly, there will be crisscross involvement of the adhesion can be possible. Even in any joint. So the spinal joint also is not least. So it can be, the adhesion can be there. While manipulation, this articular and periarticular adhesion can be disturbed, so the movement will be allowed. Then unbuckling of the motion of segments undergone disproportionate displacements. There is a motion segment as Dr. Sudhi mentioned about the articular facets and the that motion segment, some undisturbed unbuckling of it is buckled together. So that is unbuckling happens, it can be easily, manipulation can do it. Then reduction of the disc bulge. Not in the acute condition, you never go for acute condition, there is manipulation. It has to be settled how far it is there. Then settlement, after settlement, reduction of disc bulge can be possible with manipulation. Repositioning of the minuscule structures within the articular surface. That also possible. That means wear and tear of the linear tear, as I mentioned earlier. This can be corrected by the repositioning of the minuscule structures within the articular surface and change in neurophysiological function and reduction of muscle spasm. This is the most important, and ultimately if this fails, another management is the surgery. Where surgery is indicated, you can go through the immediate bowel alteration or your micturition is involved, then you can immediately have to go for surgery. Otherwise, all others are, you can wait for other management also. Then comes the Ayurvedic consideration. Only two parts, that is Kadigraha and Gripasi. We can correlate all back pains, not only spondylosis, all IVDP, all other listhesis, only Ayurvedic description is only about Kadigraha or Gripasi. That means only very less description of Ayurvedic references are there, but we are ready to treat with this lesson. The majority of the disorder we are treating with indifference, definitely with the difference. Disc prolapse and other things, and this spondylosis we manage entirely different. So that means we applied Ayurveda, even though we are not getting this much discussion from the text how to do for a particular condition and all, we are able to do it. But only for these things. Other lesser description will say, oh, that is very less description, so we are not treating. Because I am just giving an example of heart diseases. We are not, the Ayurveda has not much description, so we are not treating them. We are not handling. Other things is that about cancers. That also less description we are not treating. But Ayurveda, basically because of fear psychosis, we are not entering into that areas. Even this back pain, we are entering also, nothing will happen. Sometimes the pain will leave, sometimes it may exaggerate. Nothing, no death will occur. But other heart disease and the cancer condition, the Ayurveda fellows are entering, and something happens, definitely death can occur. So that we are having Ayurveda having fear psychosis, so we won't try to enter into that fields. But even though very less descriptions in, about back pain, we are strongly intervening this back pain area. Then Kadigraha is described as a disease in Graha only. There is no classical test works referred about it. Either Ashtanga Hridaya or Susruta or Charaga never described it as an individual disorder. But it is considered two words, Kadi and Graha. That's Kadi, Graha, that is restriction of movement only. That simple word meaning is only Kadi, restriction of movement. And this is a condition characterized by the vitiated vayu, either Shuddha, Sama or Niromava. That is a description. It can either two conditions, Sama or Nirama can be there. Then the Samprapti, that is just like Ukta Nidana Sevana, that is Vada Kama Nidana, or Vardhakya leading to Dadachaya, then also that goes to Vada Pragoba. That Nidana Sevana or Vardhakya can ultimately lead to Vada Pragoba. And the circulation, then Slesha Kapha in Sandhi, that because it is occurs in the Sana, it is Sandhi, Slesha Kapha, then Kavaiguna in Sandhi of Kadi, and Sthana Samsraya in Kadi and Kadi manifest as a Kadi Graha. Then what I can go for the Samprati Khadagas. Dosha is Vada, particularly Vyana and Abana, that of course that's to Vritti. And another dosha involved is Kapha, that is Sleshaga Chaya is there. Sleshaga Chaya, because Sandhishu Sleshaga is there, Chaya. The two Vada, Vritti, and of course it can be like that only, because if the Vada is vitiating, then Kapha definitely it has to be reduced. So Vyana and Abana and Sleshaga Chaya occurs. Dusha is Asti, Asti, and Upadado is Snayu. And Udbhavasthana is Pakvashaya, and Vyaktasthana is Kadi. Sanjarasthana is Arthasharira, and Srodhas is Astivaha and Purishavaha, and Dogamarga is Madhyama Dogamarga. Then Vayu Kadyasra Suttosama Janayad, that only this Kadi Graha, only the symptoms were described. That is only you will get Pakashastho, Ambra Gujanam, Sulam, Adobam, Krichamutra, Purishka, Anaham, Triga Sula. We are otherwise Kadigraha or Trigasula or Kadisula are as we, because we refer all the items in the textbooks, or we have published a book of the law back management by Department of Selladundra at Triponpura. So we refer to only this, all are mentioning about the Skadigraha only. Trigasula or some textbooks will be referred like that only. Then if it is a Grithasi, it can two types. It can predominantly dominated by Vada or Vada Kamacha.